see the management part. But first, we will talk about the pressurized intraperitoneal chemotherapy, pressurized intraperitoneal aerosol chemotherapy, that is PIPEC. And PIPEC has been proposed as an alternative mode for intraperitoneal chemotherapy delivery, in which chemotherapy is delivered laparoscopically as pressurized aerosol to enhance tumor penetration for patients with unresectable peritoneal carcinomatosis. In a single arm phase 2 clinical trial, the use of palliative PIPEC was examined in 20 patients with isolated unresectable colorectal peritoneal metastasis, and patients underwent repeated laparoscopic PIPEC procedure. Median hospital length of stay was 1 day, and grade more than equal to 3 complication occurred in 15%. So this is the PIPEC machine. Here we can see this is a high pressure injector. One injector is there, and this is the micro pump, and this is laparoscopy CO2 insufflator, the normal port we place, and there is micro pump. This is video monitoring, closed aerosol waste system, access trocar. So pressurized intraperitoneal aerosol chemotherapy, which is performed laparoscopically in operating room, where a liquid chemotherapy drug is vaporized. So chemotherapy in a liquid form, then it is vaporized using standard injector connected to nebulizer. So this is one patient of unresectable pseudomyxoma peritonei. So response in ascites seen in 56% with PIPEC, whereas ascites progressed in 19%. In a retrospective study that included 14 patients with gastric cancer with peritoneal metastasis, most, that is 79% patients had decreased or stable ascites volume, whereas 21% progressed. Although data on safety and response from PIPEC are encouraging, the durability of response and its impact on quality of life are the subject of debate. So now we will see how to manage ascites, different methods of management. So management of malignant ascites evolved from the contribution of many specialties, including surgical onco, med-onco, hepatology, then palliative care, interventional radiology, and the mainstay of treatment have been based on non-malignant ascites and include diuretics and paracentesis. More recent studies have demonstrated a paradigm shift in the treatment of malignant ascites. Newman and Pudney surveyed 804 patients in UK, and revealing that 75% employed paracentesis, 91.9% prescribed diuretics, and 50% used indwelling peritoneal catheters, and 13% administered intraperitoneal chemotherapy. Similarly, in a study of more than 100 physicians in Germany and Australia, Jen et al. Reported that 89% perform paracentesis, with 75% and 55% recommending concomitant systemic chemotherapy and diuretic therapy respectively, whereas 7% of the patients received targeted immunotherapy treatment. And such variation in management of malignant ascites reflects the paucity of data on which to guide management of this common problem. Goal of malignant ascites treatment are to provide symptomatic relief to either maintain or improve quality of life. Common endpoint of clinical studies have included time between paracentesis, that is paracentesis free survival, and malignant ascites resolution complete or partial response. And in the past few years, new systemic agents and regional chemotherapy combined with surgical cytoreduction have offered alternative options for palliation. Randomized control trials have shown the efficacy of targeted antibodies in the treatment of malignant ascites, and this include intraperitoneal cartumaxomab therapy. So it is a monoclonal trifunctional monoclonal antibody that binds to the epithelial cell adhesion molecule. Efficacy of cartumaxomab for gastrointestinal malignancies and other novel targeted antibodies including VEGF inhibitors, aflibercept, and bevacizumab in the treatment of malignant ascites remain in the studied armamentarium. Surgical strategies such as drainage with or without intraperitoneal chemotherapy may benefit a subset of patients with mucinous peritoneal tumors, and the various options for the treatment are reviewed. So mainstay treatment is diuretics. The use of diuretics in the management of malignant ascites is largely extrapolated from the treatment of cardiogenic or cirrhotic ascites. Although it has been advocated as first-line treatment of malignant ascites, there are no level 1 data evaluating diuretic efficacy. As a result, its use remains controversial and without clear guidelines, and it may be most useful when the etiology of ascites involves stimulation of the renin-aldosterone axis. So as a result, diuretic use is most successful in selected patients with liver dysfunction or portal hypertension. So diuretic use is limited for liver dysfunction and portal hypertension secondary to metastatic liver disease, extensive intrahepatic primary tumor burden as opposed to patients with peritoneal disease. And for this reason, patients with a serum to ascites albumin gradient of less than 1.1 have found to be less responsive to diuretic use as was identified in a prospective study of patients with malignant ascites of various primary tumor etiologies. A review of 5 studies with more than 100 patients with malignant ascites from a variety of primary tumors found the use of diuretics to be successful in the managing symptoms in up to 43% patients. And the agent most commonly used is spironolactone, with dose ranging from spironolactone 150 to 450 mg per day, 150 to 450 mg per day, and loop diuretics such as furosemide can be added to spironolactone. The maximal expected ascites reabsorption can reach up to 800 ml with optimized medication doses in selected patients, although it must be realized that no change in ascitic volume can be expected to be achieved in patients with malignant ascites secondary to peritoneal carcinomatosis or chylous malignant ascites, and complications for diuretics use such as dehydration, renal toxicity, electrolyte imbalance, and that results in cardiac arrhythmias. Second is paracentesis. Paracentesis is the most commonly used treatment for patients with malignant ascites, with up to 98% physicians utilizing modality of for patients. Improvement in symptoms, although temporary, can be achieved in 90% of this patient, and the volume of drainage per session is limited by the potential complication of hypovolemia and resulting hypotension or renal dysfunction. Although hypovolemia and hypotension may be averted with concomitant 5% infusion or IV albumin. Randomized studies have demonstrated no difference in survival between patients treated with albumin and patients treated with other plasma expanders, and for patients with malignant ascites. No definite trial on these subjects have been performed, and reports of 5 liter per 1 hour or to 2 hours were demonstrated to be safe with hypovolemia or renal dysfunction, and volume up to 20 liter per session have been reported, although there is no consensus on the rate withdrawal ranging from 30 minutes to 20 total of 48 paracentesis in 44 patients with malignant ascites suggests that removal of a mean of 5.8 liter can provide palliation of symptoms, and serial paracentesis can result in hypoalbuminemia complications, possibly minimized with high protein diet and small volume taps. Additional procedures risk of paracentesis and include solid and hollow viscous organ injury, perforation, bleeding, fistula, peritonitis, sepsis, and in patients with carcinomatosis and or prior surgery, there may be extensive scarring and fluid loculations, making ultrasound guided paracentesis attractive with potentially less complication in this population. As the procedure is often required in multiple occasions, efficacy decreases and complication risks compound. Furthermore, with each session, there is a risk of adhesions to the puncture site, formation of loculations, and cumulative decrease in the location and accessible volume of fluid over time. In a study of 67 patients with ovarian, breast, colorectal cancers, 392 paracentesis or approximately 6 aspirations per patient were required for palliation, with other studies reporting mean procedure free interval to be 10 days to 11 days. Current clinical trials include endoscopic ultrasound guidance, drainage. Indwelling peritoneal drainage catheter. The major drawback of repeat paracentesis is that ascites tend to reaccumulate and symptoms often recur. To overcome the risk, potential complication, and patient discomfort, indwelling peritoneal catheter drainage that has been advocated, and this catheter offer option of self drainage, and the utility of catheter placement should be weighed against patient's condition, since survival from catheter placement ranges from 15 days to 18 months. Typical patients with a life expectancy of 2 to 3 months requiring serial tapes are considered for this procedure, and the most frequently used option include tunnel Hoff catheter, untunneled or tunneled Plur-X catheter, and Cope type loop catheters, tunnel peritoneal port A cats. Tunnel catheter appear to have a similar efficacy and patency rate of more than 95%. Control of ascites ranges from 83 to 100% of the patients with mean patency duration of 52 days. The greatest risk with indwelling catheter is peritonitis, which occurred in 4.4% of the patient with tunnel trench cough catheter and 2.5% of the patients with tunnel Plur-X catheter, compared to reports of 21 to 34% untunneled. Other complications that occur in 25% of the patient with untunneled catheter include leakage from the insertion site, cellulitis, infection, occlusion, and fetal hypotension. Compared with serial paracentesis, indwelling peritoneal catheters have been found to be more cost effective, translating into significant reduction in hospital stay, fewer readmission, lower complication. So peritoneal venous shunting. Shunting involves removing fluid from peritoneal cavity and returning it to the venous circulation, like into superior vena cava, with the goal of maintaining electrolyte and proteins, compared to drainage. And most commonly employed is leave-in catheter and Denver shunt. And there is no level 1 evidence comparing shunt efficacy in malignant ascites. Contraindication to shunt placement include hemorrhagic ascites, loculation, heart disease, renal failure, jaundice, portal hypertension, pleural effusion, clotting, fat disorder. Theoretically, there is a risk of systemic seeding from positive peritoneal cytology, but this has not been found to be clinically significant. Although shunt placement would be advised only in select patients with prolonged life expectancy, survival have been found to be approximately 30% in one study and range from 52 days to 266 days in a comprehensive review with perioperative mortality as high as 20%. Leave interventions have 78% control of ascites and 70% subclinical. Gastrointestinal malignancy relatively contraindicated, and surgical shunts for palliation for malignant ascites can be associated with kinking or occlusion in almost 1/3 of the patients and significant morbidity and mortality in nearly half of the patients. Highly selected patients with prolonged life expectancy, surgical shunting may provide palliation with known procedure-related morbidity and mortality. Then there is regional treatment like cell-free and concentrated ascitic re-infusion therapy with intraperitoneal chemotherapy. CART is cell-free and concentrated ascites re-infusion therapy. So it is a type of apheresis that has been approved in Japan but yet to be adopted in the Western countries for symptomatic ascites, malignant ascites. And paracentesis carries the risk of significant protein loss and decreased circulation volume. CART allows for preservation of this protein such as albumin and globulin by removing cells from the ascitic fluid and returning protein from the drained ascitic fluid back into the patient. And this CART is performed in patients with malignant ascites and include 4 steps: ascites, paracentesis, then removal of cell components including cancer cells from the ascites by filtration with a plasma separating filter, then concentration of fluid by removal of the isotonic salt and water by filtration with the dialysis fluid, and IV reinfusion of fluid into the patient. When intraperitoneal paclitaxel is combined with CART in gastric cancer patient with massive malignant ascites, 22 of 30 patients demonstrated full remission of malignant ascites without major complication with a median survival of 10.2 months. And when intraperitoneal paclitaxel is combined with CART in gastric cancer patient, 22 out of 30 patients, they showed complete remission. Cell-free and concentrated ascites reinfusion therapy, CART. Another is intraperitoneal chemotherapy, cytoreductive surgery, and hyperthermic intraperitoneal chemotherapy. Goal of intraperitoneal chemotherapy is to expose tumor cells to higher concentration of toxic chemotherapy, and the theoretical mode of action involves direct cytostatic effect plus ensuring fibrosis. Direct cytostatic effect: this fibrosis, scar formation, inhibiting peritoneal secretion and limiting free volume of peritoneal cavity. Penetration of the selected chemotherapeutic agent into the tumor is critical and optimal tumor bulk is less than 2.5 mm recommended. So cytoreductive surgery is often required with intraperitoneal chemotherapy to improve outcome, and cytoreductive surgery for malignant ascites has historically been reserved for palliation of symptoms or emergent need to relieve obstruction or perforation. Complete tumor clearance in patients with peritoneal carcinomatosis is rarely achieved with surgery alone. The cytoreductive surgery with hyperthermic HIPAC or EPIC has been performed to improve survival, prevent redevelopment of malignant ascites, and this can be an extensive morbid surgical procedure involving removal of all the involved visceral, parietal, peritoneal surface and organ resection when stripping is not possible. Hyperthermia with selected chemotherapeutic agent can enhance cytotoxicity. Through improved tissue penetration and reduced drug resistance. Agents used in HIPEC is like mitomycin C, oxaliplatin, paclitaxel, cisplatin, etoposide, gemcitabine, 5-fluorouracil. And in a retrospective study for HIPEC, resolution of malignant ascites was achieved in 93% of the patients within 3 months. Complete cytoreduction was not feasible, even when complete cytoreduction was not feasible. A major morbidity was 25% and 30-day mortality is 5.8%. And this study included patients with different primary diagnoses like appendiceal, colorectal, gastric, mesothelioma, ovary. Resolution of malignant ascites was independent of primary type, completeness of cytoreduction, or chemotherapeutic agents. Vital reported a study of cytoreductive surgery with HIPEC is effective in controlling malignant ascites. Cytoreductive surgery with HIPEC. 100% regression of malignant ascites after cytoreductive surgery and HIPEC, as well as median disease-free and overall survival times. HIPEC is an effective therapy in decreasing malignant ascites in patients with advanced ovarian cancer. Rates of control of malignant ascites with HIPEC range from 67 to 100% depending on the type of histology and chemotherapy agents. PMP in particular have demonstrated promising results, and ovarian cancer seems to be most sensitive to local peritoneal chemo, and success appears improved when limited to microscopic disease. And although malignant ascites secondary to metastatic gastrointestinal malignancy is often resistant to systemic chemotherapy, studies from China and Japan have shown promising efficacy in controlling malignant ascites using different intraperitoneal chemotherapeutic agents. Ba et al. Reported results from a randomized trial that compared repeated application of heated intraperitoneal chemotherapy like oxaliplatin followed by raltritaxel and 5-FU before and after cytoreductive surgery for malignant ascites secondary to colorectal cancer. All patients included achieved complete malignant ascites remission, and adverse events included bone marrow suppression in 19%. One patient required hemodialysis. Intraperitoneal paclitaxel with oral S1 was associated with response in malignant ascites in 61% of the patients. Minimal invasive surgery with HIPEC may offer less invasive approach to achieve a similar goal. HIPEC with laparoscopic HIPEC with cisplatin, doxorubicin or mitomycin C resulting in a resolution. Laparoscopic HIPEC has some promising in treating malignant ascites for gastrointestinal malignancy with 100% remission rate observed in a study of 38 patients with gastric cancer, and this minimally invasive approach is also associated with a low morbidity, minor wound infection, deep venous thrombosis, shorter hospital stay. So laparoscopic HIPEC can be safe, effective tool in improving symptomatic malignant ascites.